read studies about the science of heart attack and stroke prevention, you're going to see this term sooner or later, Mendelian randomization. Now, what the heck is that? And why is it important? What's it used for? Well, the age of genetics is clearly upon us. And one of the things that epidemiologists study authors in multiple areas, ranging from bone transplant to drug development to prevention, all are beginning to discover this technique. And what is it? It basically takes the fact that genes tend to be distributed at random. So let's say your father has one blue-eyed gene and one brown-eyed gene, so he's got brown eyes. And your mother has blue-eyed genes, so she's got two blue-eyed genes. Your father's got one blue-eyed gene, one brown-eyed gene, so both his eyes are brown because brown's dominant. Your mother has two blue-eyed genes, so both eyes are blue. What will the kids be? Well, we know brown is dominant, so half the kids will have brown eyes, half the kids will have blue, because half of them will have gotten the father's brown-eyed gene and the mother's blue-eyed gene, so they'll be brown-eyed. Half will have gotten the father's blue-eyed gene and the mother's blue-eyed gene, and they will be blue-eyed. Here's what we don't know: which half. And so that's what we mean by a random distribution of genes, genetics. What researchers have begun to realize is they can take that randomization and in many ways use that to replace some of the function that we see in randomized clinical trials. Let me give you an example. Does being obese cause a heart attack? Or is something else that's causing obesity also cause that heart attack? Well, they've actually done studies on that, and that's how this came up in our channel. I'll talk about those studies in just a minute. But let's go back again a little bit more into the history of Mendelian randomization. It's credited to these two authors, Gray and Wheatley. And as you can see, they're not so much epidemiologists as they are bone marrow transplant guys. And they came up with this idea on how to avoid bias when comparing bone marrow transplantation with chemotherapy. Now, actually, there was an author before that, Ketan. He was in more of the prevention area. He was talking about apolipoprotein E isoforms and cholesterol and cancer. Again, I'm not going to go into either of those studies right now. I'm going to talk a little bit more just about the whole concept of Mendelian randomization. Now, we first talked about it as we were going through the obesity paradox, when thinner means sicker and heavier means healthier. I'm not going to get deep into those studies or those concepts, other than to say that as we studied that, we found that this was very much related to the issue of lethal sarcopenia. And again, we had several videos that covered those issues. We're not going to spend any time on those. We're going to go straight to the article that brought up Mendelian randomization for us. And that had to do with obesity and cardiovascular outcomes. So I just mentioned that a few minutes ago. There was a study in JAMA Cardiology, the open network group, where they did a meta-analysis. You know, the Cochrane studies, where you take multiple studies and you pull them together to see what they show. But these were a unique type of study. In fact, they only found 5 of them. It's a study where you do this. You take a large population. These were called GWAS, genome-wide association studies. So they took a large population. Each of these studies did that. They looked at genes that are associated that appear to cause obesity, and there are some. If you didn't know that, yes, obesity does have clearly a genetic component. So they separated those out here and looked at the rates of heart disease. They compared that in the rates of the heart disease in the control group, the people that did not have the genes for obesity. Here's what they found. Yes, the people that had the genes for obesity had increased risk for not only heart attack, but diabetes as well. So very interesting and in many ways not surprising. There was one surprise twist, which I don't think we can explain. If you want a bottom line on that, I think the bottom line is still mystery. In that same study, they did not find that relationship with stroke. You saw the same amount of strokes in both of these populations, the study population and the control. Now, were these big studies? Yes, the total was almost 1 million. So statistically, very powerful studies. And again, now why did they have to use this technique? And again, as we begin to discuss it, I think it becomes clearer what Mendelian randomization is about. Let's say we wanted to find out, does obesity cause heart attack and stroke? Well, if you're going to do a randomized clinical trial, first you have to get a large group and you have to randomly assign obesity to one group and not to another. You can't do that. How are you going to say, okay, we've picked 100,000 people and this 50,000 is going to become obese? You can't do that. Obesity and its relationship to something like heart attack is always going to be what we call an observational study. But let's go on. Let's just humor ourselves here and say there's a way that we can randomly assign and make somebody obese. You know, there's a thing called blinding as well. In other words, you have to blind the patient and the healthcare provider, the doctor, to the fact that this person has the exposure and this one doesn't. In other words, how are you going to blind the patient and the doc to the fact that you've made them obese? Again, just will not happen. That's why we get into this question of randomization and bias and confounding, and since you can't use randomized clinical trials, use the randomization of genetic distribution. So if that's still making your head feel kind of hurting and turning inside out, trying to link those two, you're not the only one. There's whole textbooks on how to do this. I will also share, there's a Mendelian Randomization boot camp at Columbia University later on in 2019. If you really want to go, you can spend a few days talking about exactly how to do that. But it might be helpful if I go back and use another example of Mendelian randomization in prevention. And it has to do with c-reactive protein. Now, those of you who've seen any of my, have seen many of my videos will remember c-reactive protein. I've got several videos on it. And if you don't know what it is, take the inflammation course. In the inflammation course, I tell you how to find out whether or not you have cardiovascular inflammation. One of the key studies for cardiovascular inflammation, one of the key labs is CRP, c-reactive protein. C-reactive protein is made by the liver when there is inflammation going on in the body. The guy that came up with this whole idea that cardiovascular inflammation causes heart attack and stroke, Paul Ridker, a very smart guy at Harvard, that's really all he uses. I tend to use more than c-reactive protein. I also use microalbumin creatinine ratio, MPO, Lp(a). But let's go back to CRP and Mendelian randomization. So there are genes that are, as we said before, excuse me, randomly distributed, genes which cause high CRP. So let's ask the question, does having an elevated c-reactive protein cause heart attack? Or is there a confounder? Something that biases the study for people that have elevated CRP. Well, since we know there are genes that will create elevated CRP in people. There are genes that, for example, slow down the breakdown of c-reactive protein. If we can look at those, find those genes, then what we can do is this. Again, take a large population, find those that have genetic elevated CRP. Now, if that group has higher heart attack and stroke risk, then we know that CRP actually causes it. If it doesn't have a higher heart attack and stroke risk, it's the same as the group that does not have genetically elevated CRP, then it's not the CRP that's causing it, because you got a higher CRP in the genetic risk group. So again, that risk group, if the CRP were causing it, should have more heart attacks and strokes. And here's exactly what you see on the image behind me. When we do testing, if your CRP begins to elevate, yes, you are much more likely to have a heart attack or a stroke. However, if you do, again, a genome-wide GWAS, or if you just do a genetic study, you pull these groups and you look at them. The groups that have genetically elevated CRP do not have an increase in heart attack and stroke. Their relative risk is 1. So what we know is that elevated CRP is a marker, not a cause of heart attack and stroke. So for those of you that have made it this far, as usual, and this time especially, we did some mind-bending stuff. I'm not the greatest public speaker, as I get reminded routinely in the comments section, but I do have a passion for helping people understand the science behind prevention. I hope this has been helpful, and maybe even just a little bit eye-opening in terms of the science and what's happening out there today. Thank you for your interest.